Good morning. I'll start sharp at 11 a.m. I hope you are still all doing well. The ones that joined us on Tuesday, um, welcome back. For whoever is joining us for the first time, welcome. Today's topic is quite a hot topic, and it's a very prevalent disease and conditions, and I hope I'll bring some light to the tunnel. As we did on Tuesday, I've prepared today's webinar for around 45 minutes. Morning, Louise. And we'll have a few minutes at the end for questions and answers. So feel free to write your questions on the Q&A icon, and then, like we did on Tuesday, we'll go through those questions, the ones we cannot answer, and there were a lot on Tuesday. We'll try to answer them through the email, or hopefully in another opportunity we may have to meet again, either online or hopefully in the near future face to face. Today I'm alone with my kids. My wife went out to work at the A&E, so if we do need to interrupt this, it's because there's crisis. So hopefully that will not happen. They usually behave, and hopefully that will be the case today again. But if you hear any sounds, unless it's something unexpected, you know what it is about. So let's check the time. We still have two more minutes. We are going up in the number of participants. I'm glad to see that you're all eager to join and learn a little bit more about peri-implant diseases and conditions. So like I said on Tuesday, write your questions in the Q&A tab, and we'll answer, or we'll try to answer them at the end of the session rather than interrupting. This is a webinar, so it's not a meeting where you can interact more easily. So it's a little bit of a monologue from this side, looking at the screen. I can't see anyone. Hopefully you'll be able to see me. I was told on Tuesday there were a few breaks in the connection. Wednesday things went a lot better. I will ask Louise to stop me if for some reason my image has frozen, and I'll stop, and then I'll resume and eventually go a little bit further back. So we are now, it's now 10 a.m. So for the ones that have joined now, welcome. Welcome back, or welcome to our tip and training webinars. Today's topic is the diagnosis of peri-implant diseases and conditions. I'll introduce myself. So my name is Hugo. I'm a specialist periodontist. I live in Oxford with my family. Teach at the University of Manchester, the master student, and Alcântara is a neighborhood in Lisbon where I'm starting a new project around this corner there. And well, Manchester is our headquarters for tip and training. Hopefully I'll be able to enjoy the scenery in the near future. But at the moment, this is a picture taken from my terrace in Portugal a couple days ago. A beautiful rainbow that brings us hope, and hope that everything will be okay as soon as possible. But the topic for today, like I said, is the diagnosis of peri-implant diseases and conditions. So let's say when we all come back, one of the referrals to me is this panoramic X-ray. And without any clinical information, it's impossible to tell if there's any peri-implantitis around any of these three implants. Of course, we can suspect there is peri-implantitis on the implant at the lower left 6, because we can see bone loss. On the lower right 7 as well, although not as deep. There's also some signs of bone loss. The one on the upper left 6 seems fairly stable in terms of the bone level, but without a clinical assessment, we can't just say it's peri-implantitis, because as you'll see, we can have peri-implant health on an implant with a reduced bone support. Let's say this is one of my patients that got referred to see me to improve the quality and the amount of tissue around the upper left 2 implant. This is after the healing stage, the provisionals have been removed, and the idea at this stage is try to understand if the tissues are healthy. And we'll go back to this case later on. Or this one, this is a 1-year follow-up to the lower left 6 implant, a bone level implant. And well, the implant on the lower left 7 had been placed 11 years ago. Same company, 2 different implants, and from the X-ray, the bone level seems quite good, but then a clinical assessment would be necessary to make sure everything is okay. And this is what we can see in here. An implant placed over 10 years ago on an upper left 2, and the patient has some discomfort, occasionally some separation. We can already see clinically, just visually, that the tissue is not very thick, that the margin there is quite thin, and there is a little bit of recession. And when we look at the X-ray, we can see that there's definitely some signs of bone loss, and I can tell you that there were also deep pockets mesially and distally and mid-buccal to this upper left 2 implant. Or this X-ray from an Astra implant, where the bone level seems fairly okay, considering that we may lose up to 2 millimeters during the first year. But then clinically, you see the gray shadow through the gum margin, and you see that you've lost the papilla. So this may not really be considered a complete success. And whether there is peri-implant health or mucositis, it's difficult to tell without putting a probe in. So this is what we'll be discussing. We won't be going into treatment today. That is probably a topic for another webinar. But today we'll go through what are peri-implant diseases and conditions. For peri-implant diseases and conditions. What steps will we need to follow to reach a diagnosis? And then I'll present a tool that was recently published that analyzes the risk for the development of peri-implant diseases, and will hopefully come to clear conclusions about today's topic. So what are we talking about? Implants are a tool for everyday dentistry. And we know that once implants are integrated, they are able to support crowns, bridges, full arch rehabilitation. So they've become an increasingly popular option to replace absent or lost teeth. And we have evidence, plenty of evidence reporting on survival rates up to 5 years, around 92%, up to 10 years of around 89%, presented by Thomas, but we need to differentiate between survival rates and success rate. So survival means the implant is still in function, regardless of its aesthetic, of the quality of the tissues, and even of the bone level around the implant. Whereas success rates will analyze a lot more aspects, even patient-related aspects that cannot be as objective, like the aesthetic. And we do know, and that's fairly clear, that our working functional implants and their crowns or bridges may be subject to both mechanical and also biological complications. So what are peri-implant diseases and conditions? On one side, we have these biological complications that are linked with dental implants. They are mostly inflammatory conditions. They can affect both the soft and the hard tissues that surround our implants and the restorative components, both abutments and crowns. And we know that it's the bacterial biofilm that induces these inflammatory conditions, these biological complications. But we also have other conditions that are associated with tissue deficiencies. And these deficiencies are very common when implant rehabilitations are not well planned, or when we don't follow the prosthetically driven concept, or when we don't prepare the sites in terms of hard and soft tissue well enough to have the implant perfectly driven by the position of the crown. So these type of deficiencies can lead to an increase in bone loss at the margin, an increase in recession, and also soft tissue inflammation. These deficiencies can be related with hard tissue defects, and these will be intravalvular defects, dehiscence or fenestration-like defects, or horizontal vertical ridge defects, but they can also affect the soft tissues only. And it's usually associated with a lack of volume or quality. And quality usually relates with the lack of keratinized mucosa. So before we go into the disease, it's important to understand the anatomy and the histology of the peri-implant mucosa. So peri-implant mucosa is the name we give to the soft tissue that surrounds the implants. And they do share some features with gingiva, which is the soft tissue that surrounds the teeth. And the seal that these soft tissues around the implant, so the peri-implant mucosa creates, is this seal is essential for the long-term maintenance of the stability and the function of the implant that's loaded. And this seal is established quite early during the healing period, and its maintenance is crucial for our success. These images are from a classical study published by Berglunds in 1991, and it shows the histological features of both the periodontal tissues and the peri-implant tissues. The common characteristics they share are related with the oral epithelium, which is fairly much the same. Then there is a sulcular epithelium, which again, we have a similar one around implants. And the difference then goes into the further deeper tissues. So around teeth, we have a junctional epithelium. At the implant, we have a barrier epithelium, which is similar, but not exactly the same, although we still have the same desmosomes or hemidesmosomes that connect these soft tissues to the surfaces. The connective tissue is fairly similar, although in terms of amount of blood vessels and fibroblasts, it's slightly different. And then one of the huge differences is the fact that we have the periodontal ligament around teeth, which we don't have around implants. So implants, we have close contact between the bone and the titanium or the zirconia, and we have supraalveolar fibers, but the fibers of this connective tissue are circular, so they go around the implant, and go parallel to the implant, and there's no perpendicular fibers towards the implant surface, which makes the structural anatomy of these tissues slightly different. Also, in terms of thickness, we know from studies carried out in animals that the thickness of this peri-implant mucosa is really important. And the same thing as happens around teeth, where we have a biological width, here we also seem to have a biological distance that we want to keep stable, or the body wants to keep stable. So if you're facing a very thin peri-implant mucosa, you're likely to get bone loss to re-establish that biological space that is around 2 millimeters. And this is what was proven in this study, where they had a very thin mucosa that ended leading up to bone loss, and then control with a thick mucosa that did not happen. In terms of etiology of the peri-implant diseases and conditions, this is a recent study by Frank Schwarz in Germany, and what they did was an experimental peri-implant mucositis. And this was to prove if biofilm was in fact the cause of peri-implant mucositis. So what they did was they've placed implants in healthy individuals, and after 12 weeks, which was the healing stage, they've asked the participants to stop any oral hygiene measures around the implant. So they were still allowed to brush and floss around any other teeth, but for the implant that was included in the study, they would not be able to brush nor floss. And that exposure phase lasted for 21 days. At visit 8, so 21 days after this exposure phase without any oral hygiene measures, the implant sites were addressed professionally for plaque control, eventually even using some carbon curettes and polishing. And then the follow-up went for a few more weeks, 16 weeks, for 4 months. What they, in terms of primary outcome, was the presence of inflammation. So they wanted to understand if the exposure phase led to inflammatory signs, namely assessing bleeding on probing, increase in pocket depth, and also assess the amount of plaque accumulation. And then during the resolution phase, they wanted to prove that resuming oral hygiene measures would lead to the resolution of the peri-implant mucositis. They also did some microbiological testing and some immunological testing to check the MMP8, just to try to understand if this plaque accumulation led to inflammation that could be caused by a change in the flora within the sulcus, and if this also showed some changes in terms of the immune system. So these images represent the exposure phase, so the time during the 21 days where the participants were not able to brush. And you can see at day 0 of the exposure phase, the tissues are very, very healthy, no probing pocket depth, no signs of plaque, no bleeding on probing. At day 7, you could already start seeing the plaque accumulating, but still no increase, no significant increase in pocket depth measurements, and definitely no signs of bleeding on probing. At day 14, there was evident bleeding on probing, and the pocket depth was increasing. And at the last day of the exposure in the specimen, You could see a deeper pocket, profuse bleeding, plaque, so obvious signs of inflammation. Then the participants entered the resolution phase, where, like I said, they were subjected to professional plaque control measures with curettes and polishing. And you can see that at week 2, no plaque, and visually the tissues look a lot better. And at week 16, so the 4-month follow-up, the pocket depth went back to how it was before, with no signs of inflammation and no recession. So what this study shows is that plaque definitely plays a role, and it's a crucial and essential role for the development and initiation of peri-implant mucositis, and that peri-implant mucositis seems a reversible disease that once we resume oral hygiene, adequate oral hygiene measures, the clinical signs of inflammation disappear. In terms of the classical microbiology of peri-implant diseases, and this was extensively studied by Mumbelli, it's very similar to what we see with periodontitis. So the same bacteria associated with success and stability, the same suspects, usual suspects that we can associate with failure. But apart from this, from plaque and the biofilm as the main etiological factor, we also need to consider a few risk factors and indicators. Dreyer in 2018 published a systematic review that categorized the risk factors into its level of evidence in the way they are linked with the development of peri-implant diseases. And a few factors, gathering all the information from different studies, were considered to have a medium and high level of evidence being linked with the progression of peri-implant diseases. And these factors are history of severe periodontitis, poor plaque control, no regular maintenance care once implants have been restored, smoking habits, and non-controlled diabetes. A few other factors showed limited evidence, but still some connection with the possible progression of peri-implant diseases, and these were osteoporosis, the amount of keratinized mucosa around the implants, the type of implant surface, and the existence of a full edentulous mouth. And there were some factors like age, gender, and maxillary implants that showed no evidence of a link. Well, actually, the results they came to, or the conclusions, were that there was high evidence that there was no link at all between age, gender, and maxillary implants with the establishment of peri-implant inflammation. Keratin mucus around implants, it's been a controversy in the literature, and we have a lot of papers that will say that yes, we definitely need keratinized tissue and we need a certain amount to provide stability to our implants, but other studies will state that no, regardless of the amount of keratinized mucosa, the implants, that is not related with the health condition of these implants. Lin and collaborators in 2013 published a systematic review, and their conclusions were that based on the current available evidence, so around up to 2013, a lack of an adequate keratinized mucosa around implants is associated with more plaque accumulation, tissue inflammation, marginal recession, and attachment loss. And what the group that classified peri-implant disease and conditions in the 2017 workshop concluded as a consensus was that although there was conflicting evidence, keratinized mucosa around implants seems to establish and maintain soft tissue health. It prevents recession, it helps with the aesthetic, and above anything else, it enables or facilitates the ability for our patients to perform proper oral hygiene measures around these implants. So although there's still some controversy, most authors will say that there are benefits in terms of the way the patient can brush, and the threshold for enough or not enough, most authors will say 2 millimeters. So how were these diseases and conditions incorporated into the new classification scheme that was published in 2018? Well, previously to this classification, there were definitions of peri-implant diseases. Peri-implant mucositis, peri-implantitis have been around for a few years now, and we had definitions. But what this group of periodontists from Europe and United States commented was that some of these definitions were misunderstanding. They were not fully clear. And again, they highlighted the need to distinguish between what is disease definition, so the clinical characteristics that define a disease, or a case definition, which are the steps that you need to accomplish and the criteria that you need to pick in order to say that this case is definitely peri-implant mucositis or peri-implantitis. So they came up with this with a few papers. This one is the one that presents the changes from the 1999 classification, but regarding peri-implant diseases, these have not been incorporated into any classification. So this classification from 2018 was then did then consider 4 different diseases in terms of the 4th group, which is a group for peri-implant disease and conditions. And these are peri-implant health, peri-implant mucositis, peri-implantitis, and peri-implant soft and hard tissue deficiencies. And each one of these groups was addressed by a group of specialists to come up with definitions, disease definitions, and case definitions. And these case definitions were summarized by Ranvert and collaborators. So this new classification scheme defines peri-implant health as a condition with, so peri-implant mucosa with the absence of visual signs of inflammation. And these are swelling, redness, and bleeding on dental probing. This condition of periodontal health, peri-implant health, can exist around implants with normal or reduced bone support. And it is not possible to define a probing depth range that is compatible with peri-implant health. Peri-implant mucositis is a condition characterized by bleeding on probing, on gentle probing, and visual signs of inflammation, such as swelling and redness. There is strong evidence that the is because peri-implantitis peri-implantitis is defined as an inflammation of the peri-implant mucosa with bleeding on probing and or suppuration and increased probing pocket or also with loss of supporting bone. We seem to assume that peri-implantitis is always preceded by peri-implant mucositis, and it is definitely associated with poor patients with severe itis. And then the 4th entity is hard and soft tissue deficiencies. which are usually related with decreased dimensions of the alveolar ridge that result in both hard and soft tissue deficiencies. And what this classification also highlighted were factors that were associated with this type of defects. So when you think about hard tissue deficiencies prior to implant placement, all these factors can play a role into the development of these deficiencies. So tooth loss, traumatic tooth extractions, periodontal disease, endodontic infections, root fractures, trauma in general, bone height in the posterior maxilla. So with the loss of upper molars, we face pneumatization of the maxillary sinus. So again, that bone height can be a factor that can lead to this type of deficiencies. And there are some systemic diseases that can also cause this type of problems. After defects, bone defects in healthy situations, so not triggered by peri-implantitis, implants that have been malpositioned, so too far buccally, that would probably lead to the loss of the buccal bone plate without necessarily being a case of peri-implantitis. But also peri-implantitis sometimes leads to some defects, and once peri-implantitis is sorted and stabilized, we still face these hard and soft tissue these hard tissue deficiencies, mechanical overload, soft tissue thickness, which definitely plays a role, and systemic diseases. And when we consider the soft tissues, we all know from animal studies what happens with the architecture of the hard and soft tissues once a tooth is extracted. Of course, we all know the negative outcome of periodontal disease and its treatment on to the soft tissue volume, and again, systemic diseases. And after implant placement, if there is a lack of a buccal bone, we're likely to face marginal tissue recession. We may face changes into the papilla height, and the papilla height and the distance between contact points of the crowns to the bone crest can also play a role into this. Again, the amount of keratinized mucosa, and the changes that we face with aging, with teeth and bone. So this is these are two examples of this type of soft tissue deficiency. So on the right we have buccal marginal recession, which is a result from an underlying bone dehiscency that was probably caused by the mild position of this implant far too buccally. On the left, we see lower premolar that was replaced with an implant and a single crown, and you can clearly see the loss of papilla. You can see the metal grayish shade through the gum. So here we're definitely facing a soft tissue deficiency without seeing an x-ray or without opening a flap. It's really difficult to tell if the bone is affected as well. So this is the classification, but what we also need to go through is the case definitions and what we need to do to diagnose and assess and monitor our peri-implant conditions. So oral hygiene assessment is mandatory because we know it will be the plaque, the biofilm that will trigger these inflammations. Visual evaluation, so we should be checking for visual signs of inflammation, such as change in color and change in volume. Digital palpation is important to try to assess for suppuration or any signs of an abscess. Probing with a peri-probe is mandatory as well, and at least once a year should be done. And this would not only allow us to check for probing pocket depth changes, but also assess bleeding on probing, and if needed, radiographic assessment. And radiographs should be assessing changes of bone level. So it's very important to have baseline radiographs that should be taken on the day the implants are loaded with the permanent crowns, because these will be the x-rays that can give us a good baseline. Then 1 year later, again, because we do expect some bone remodeling for the first year, according to Albrechtsen and collaborators. And at that stage, any changes are usually associated with disease. So why probe? Well, we probe around teeth to check pockets, to check bleeding. Why should we not be probing around implants? The current PPE guidelines say we should not be using VPE probe around an implant, but the current guidelines from Araújo and Linde from this classification do advise us to probe. So probing allows us to assess bleeding on probing, like I said, but also to monitor recession and pocket depth changes. And probing of peri-implant tissue using a light probing force of 0.2 newtons is safe, and it's an important component of a complete oral examination on patients that have implants. This classical study done in animals by Abrahamson and Solbini tried to compare how far does the probe go around healthy teeth and around healthy implants. And this amazing histological image shows that if the tissues are healthy, the distance between the tip of the probe and the bone at a tooth or at an implant is the same, and it's around 1 millimeter. The pocket depth, though, can be slightly different, because the thickness of the peri-implant mucosa is usually thicker than the thickness of the periodontal tissues. So a deeper pocket depth measurement does not necessarily mean that we are closer to the bone, that the tip of the probe is closer to the bone, because it is not. And this study by Chang and collaborators, published in 2006, shows exactly these differences in mucosal thickness, which is almost double around implants than around teeth. And this, of course, to increase probing depth that is not necessarily a sign of inflammation around implants. And Lang said that when you assess probing pocket depth around teeth and implants in healthy peri-implant mucositis and peri-implantitis sites, that with an increased degree of inflammation, the probe penetration increases more around implants than it does around teeth. And just to make sure that we are not causing any damage, this paper on representing a study done in animals where they've probed around healthy peri-implant tissues. And this histological image represents the gap that is caused by this probing action. After 7 days, well, actually after 5 days, we can see that the junctional epithelium is reattached and increases very quickly up to day 5, 7, and at day 7, that connection is fully established. So probing may eventually cause this space that will really quickly go back to normal. So don't be afraid of probing. Should we be probing with metal or plastic probes? There's no clear evidence to say that metal probe, when probing tissues, peri-implant mucosa, causes any damage, because you're not really touching the surface of the implant. You are at an abutment crown level when you probe. But like I said, there's no clear evidence that it's safer to use a plastic probe. What is definitely recommended is that you do probe. So in terms of case definitions, the criteria we use are probing pocket depth and changes in probing pocket depth, bleeding on gentle probing, suppuration on probing, and then bone loss assessed in radiographs. And for the diagnosis of peri-implant health, we need to have absence of clinical signs of inflammation. We need to have absence of bleeding and or suppuration on gentle probing. We should not have an increase probing pocket depth when compared to previous examinations. And we cannot have any signs of bone loss beyond the crestal bone level changes that result from the initial bone remodeling, like I said. The probing depth depends on the height of the soft tissue, like I said, and peri-implant tissue health can exist both around implants with no bone loss or implants that had peri-implantitis in the past that has now been stabilized and the tissues are back to peri-implant health, although there's been some bone loss in the past. These are two classical images of peri-implant health. Without probing, we wouldn't know, but I can tell you for sure that probing around these implants or this implant or this abutment with plenty of keratinized tissue shows no signs of inflammation. So no pockets, no bleeding on probing, no plaque, no suppuration. For the diagnosis of peri-implant mucositis, we need to find signs of inflammation, and these will be bleeding and or suppuration on gentle probing, with or without an increase in pocket depth from previous examinations. What we need to find as well is the absence of bone loss beyond the crestal bone level changes resulting from the initial bone remodeling, or of course, if you have a stabilized peri-implantitis case, no bone loss beyond the bone loss that happened due to that peri-implantitis. And this is a case I showed you at the beginning. So lady that was subjected to a connective tissue graft to increase the volume of the tissue in there, but she still presented with some discomfort around the upper left 2 implants. When probing, there was no increase in pocket depth, but palatally there were signs of inflammation with bleeding on gentle probing. So this is a case of peri-implant mucositis. We took x-rays that showed no bone loss mesially and distally, and because these symptoms persisted, we ended up doing a CT scan to see the bone level. And although the bone buccally was quite thin, the implant was still fully surrounded by bone. So it's something we need to control in terms of plaque and biofilm elimination, and hopefully be able to reverse. For the diagnosis of peri-implantitis, we need to have all the previous signs of inflammation, as for peri-implant mucositis, so bleeding on probing, suppuration, increasing probing pocket depth from previous examinations, and presence of bone loss. And if we don't have any previous examinations, what we should be looking for are pockets deeper than 5 millimeters, so 6 or above 6 millimeters, bone level 3 or more millimeters apical to the most coronal portion of the intraosseous part of the implant. And you need to take into consideration that sometimes we have tissue level implants, so you need to make sure you identify where the bone should be at a certain type of implant, and of course also bleeding and or suppuration on gentle probing. And this is the panoramic X-ray I showed you before. Now just looking into the detail of the lower left 6, where we definitely have signs of bone loss. And if this is a bone level implant, and the bone level should be here, we definitely have more than 3 millimeters. I can tell you that this case also presented with deep pockets all around the implant and bleeding on probing and suppuration. So this clinically information together with the X-ray definitely allows us to reach a diagnosis of peri-implantitis. Or this case that I showed you at the beginning as well, with a very thin buccal soft tissue volume and clinically probing pocket depth that had increased from previous examinations, mesially, distally, and mid-buccally, with bleeding on probing as well. And the X-ray definitely shows signs of bone loss. And after non-surgical treatment, which we won't go into details today, we opened a flap, and you can clearly see this type of defect, very characteristic from a peri-implantitis case. So it's obvious all the steps we need to follow for diagnosis, but it would be really important to be able to assess the risk of our patients for the development of peri-implant diseases. So a group led by Lisa Mayfield, together with Height and Lang, published very recently, so this year, a paper presenting a new tool that they call Implant Disease Risk Assessment tool. And hopefully this tool would allow us to prevent peri-implant disease. This tool is based on risk factors that have been proven in evidence to be linked with peri-implant diseases, but they also use the background of other risk assessment tools for periodontitis, like the peri-risk assessment tool developed by Lang and Tonetti and others. So what the authors created was a diagram where they took 8 factors into consideration. So starting with history of perio, which, as you saw before, by Dreyer systematic review in 2018, that had high evidence of being associated with peri-implantitis. If there is no history of periodontitis, the risk is low for this specific parameter. But if there is, then it's going to be moderate to high. Bleeding on probing percentage, and bleeding on probing, as you've seen, is one of the criteria that we require for the diagnosis of both health and peri-implant mucositis or peri-implantitis cases. So if the BOP percentage is up to 9, then it's going to be low risk of developing peri-implantitis. Moderate up to 25%, and then above 25% high risk in this diagram. The number of pockets above 4 millimeters, so pockets of 5 or above 5. If we have up to 2 pockets, it's going to be within the green part of the diagram, so a low risk. Between 2 and 6, moderate risk, and over 6, it's a high risk. The ratio bone loss by age, which is used in the new periodontitis grading system, if it's up to 0.5, which is our grade A, it's going to be low risk of peri-implantitis. Between 0.5 and 1, it's moderate, and above 1, high risk patient. If we consider perio-susceptibility, we are looking into our new staging and grading of periodontitis. So low risk, so within the green part of the diagram, is only for stage 1, grade A. Up to stage 3, grade A or B, it's moderate. And then anything more severe or more with a higher susceptibility, so a grade C or a stage 4, it's going to be a patient at a high risk of developing peri-implantitis. Then how regularly do these patients come for supportive periodontal treatment? So compliant patients, usually every 4 months, are within the low risk group, up to every 6 month moderate group, and then patients that don't come or only come casually, they are within the red part of the diagram. Then the distance between the restoration margin and the bone. And here again, you need to consider that we have tissue level implants that where the margin of the restoration is far away from the bone, or bone level implants where the margin of the restoration may be at the level of the bone. Although we have platform switching options where this may change, but what they've considered for this diagram was soft tissue level implants are within the green low risk category, and then when this distance is above 1.5, it's going to be a high risk. And then the last, the eighth criteria is the fit of the prosthesis. So a cleansable, properly fitted restoration is green, not so accessible for oral hygiene measures, but with a good fit, it's going to be moderate, and a poor fit or a cement excess that we cannot, that the patient cannot address in terms of plaque control is going to be high risk. So this diagram and filling in all these 8 parameters gives us like a spider web. And a low risk implant disease patient is whenever all parameters are within the low risk, or there's one parameter in the moderate risk. It's going to be a moderate implant disease risk patient if at least 2 parameters are in the moderate risk, or 1 in the high risk category. But if we have 1 in the high risk, all the other ones need to be in the low risk. If we have 1 in the high risk and 1 in the moderate, or at least 2 of the parameters are within the high risk category, then it's going to be a high risk implant disease risk patient. This tool, I think, is very, very useful, and I think we should all be using it for our patients. So what can we conclude from today's presentation? First, we need to be able to differentiate between health and peri-implant disease, and that should be done by visual signs of inflammation, by bleeding on probing, checking pocket depth, and increasing bone loss in radiographs. For the diagnosis, we need to assess the tissues visually. We need to probe. It's safe to probe, and it's advised. We are advised to probe because we can get a lot of information from our peri-probes, and sometimes we need to take radiographs. And in terms of this new classification, differentiating between peri-implant health and consider the disease definitions and the case definitions. So periodontal health without any signs of inflammation, no bone loss, no pockets, no bleeding on probing. Peri-implant mucositis with signs of inflammation, both visual and clinical, but absence of bone loss beyond the expected through the remodeling stage. Peri-implantitis, all of the above with bone loss, and soft and hard tissue deficiencies, mainly related with lack of bone volume and soft tissue volume or quality. Any questions we'll be able to answer now. Louise will pop them up, or I'll pop them up, and I'll be trying to answer them in order. And like I said, feel free to email me to my personal email to answer any more questions you may have. So here is my email. So you can save that slide, print screen, write it on your diary, take a picture with your phone. What is the normal bone loss expected after implant placement? So according to Albrechtsen, in its success criteria published in 1986, we expect up to 2 millimeters of bone loss during the first year after the implant has been loaded, and less than 0.2 millimeters in every year afterwards. Can you please explain probing depth in normal healthy tooth and normal healthy implants? So when we probe around an healthy tooth, the tip of the probe will get to the most coronal part of the junctional epithelium. So it basically goes into the sulcus. And we know that the sulcus depth can vary, and it can vary between 1 and 3 millimeters. And that's why we usually say that a pocket is only from 4 millimeters. When we probe around implants, the tip of the implant will reach exactly the same junctional or barrier epithelium, and it will be at the same distance to the bone as around teeth, because, and this is when the tissues are healthy, but we may expect a deeper pocket measurement, just because the tissues thickness seems to be higher around implants than around teeth, as proven by all those animal studies done by Berglund in the 90s. When comparing probing depth around implants to previous measurements to see if the pocket depth has increased, would you apply a 2 millimeter measurement error similar to teeth? I don't usually apply a measurement error. Of course, we know that even me probing today and then probing a few days later at the same site, same patient, may have a difference. What I would advise you to consider is, if you have previous measurements and there's an increase in pockets, so let's say you had 4 millimeters and now you have 6, I would not necessarily judge that these 2 extra millimeters are a measurement error. As long as you're following the right angulation and the right pressure, you should not consider these as a measurement error. And again, it's highly likely that an increased pocket will come with bleeding on probing. So if you get increased pocket with bleeding on probing, then I would suspect inflammation. On X-rays, we online see the distance mesial, how to diagnose peri-implantitis if there is bone loss buccal or lingual. So usually, bone loss that is only affecting the buccal surface is not usually caused by peri-implantitis. So it could be caused by excess cement that leads to inflammation. It could be caused by a thin buccal bone wall that was not properly increased or the implant was not properly placed. But yes, you're right. A conventional 2-dimensional X-ray won't allow us to see and assess the buccal bone level. So in order to do so, you can use 3-dimensional methods like CT scan, or only once you assess it with clinically with a probe or with surgical access. Can we get a recording of both your webinars? Louise will answer to that question later on. I believe so. I believe they are all they've all been recorded, and they will probably be available at at the typical training
They'll
webinar.
go out
Louise,
next
can you
Monday.
please comment?
Next Monday. Yes.
Thank you, Louise. So next Monday, they will be available. What factors are critical in implant cases without peri-implantitis for over 5 years and then get progressive peri-implantitis on several implants? Well, like you've seen, we have certain risk factors that have been linked with high level of evidence to peri-implantitis. And it's unclear how long it takes for plaque biofilm accumulation to lead to, well, we know how long it will take to lead to peri-implant mucositis. It's difficult to tell how it progresses from peri-implant mucositis to peri-implantitis. And we do know that once peri-implantitis starts, it seems to progress quite quickly, a lot quicker than periodontitis. So I would look out for risk factors. So was there any change in the systemic health of your patient? Is the crown still properly fitted? Was there any change in the periodontal condition of the patient? So if there's previous history of periodontitis, is the periodontitis still stable? Is the patient following a strict maintenance protocol? And if it's a peri patient, a perisupportive therapy every 3 months with your hygienist. So there are all the factors that you should be assessing. And yes, it's possible that something changes, and after 5 years of full stability, peri-implant disease or peri-implantitis starts to progress. James, welcome. I'm glad you've liked the presentation. Are you going to be giving another presentation on how to treat peri-implantitis? Well, we haven't planned anything, but I'm sure there will be plenty of opportunities in the future to discuss peri-implantitis treatment. If you want to go ahead and get ahead, you could read a really good paper by Ranvert, published in 2018, that reviews all the options, although we don't really know nowadays what is the best treatment. We don't know what's the best way to decontaminate the implant surface. We don't know if we should be removing the threads from the implant or leaving. So this is quite controversial. So yeah, definitely it would be a good topic for a future webinar. Who knows? In the implant risk assessment, would you count mild historic periodontal bone loss on the current healthy periodontium? As a yes, yes. So periodontal history, if it goes into, let me just go back to, so if you see history of periodontitis, if it's a yes, even if it's stable, it's going to be a high risk. Then you need to go into the susceptibility of that patient. So determine the risk by the stage and the grade of the periodontitis, and of course by the ratio bone level by age. So if you have a stable periodontitis, you're unlikely to have bleeding on probing, a high percentage of bleeding on probing. You're unlikely to have pockets deeper than 4, but you may, you'll still have the susceptibility and the severity of the initial disease. Maddie asks, how long should you follow up the patient for after implant placement? Really, if the patient has been referred to you from another dentist, who has the responsibility of, well, the patient has the responsibility to follow a maintenance therapy. I always see my implant patients that have been referred to me 1 year after the crown has been fitted, although I don't usually do the crowns myself, but I will make sure they come for annual review, and usually it's the general dentist or the referring dentist that follows that, unless it's a high patient or a patient that I've been also monitoring for periodontal disease. In those case scenarios, so high risk patients, I may well be seeing them once a year for maintenance. What conditions or implant placement locations do you see the most peri-implant issues in your experience? So like you've seen, the evidence doesn't seem to show that the location of the implant is crucial, and I agree. So it's more to do with how the implant has been placed, how are the soft tissues, how much bone have you got around the implant. That seems to determine the success of that implant, and also the fitting of the restorations and the access for patients to clean and their compliance in terms of the maintenance. So no, I can't tell from my clinical experience that an implant on the upper right, upper posterior quadrants are more likely to develop like peri-implant mucositis than an implant at central incisors, for example. João, hi. João from Portugal. I will read this last study for sure. I already know the risk assessment, but it is interesting, the link with the areas and grades involved. Thank you. You're welcome. I hope to see you again soon. Joan, based on the risk chart you shared, are you recommending that pocket charting should be routine prior to implant consideration? Definitely. So charting prior to implant placement is essential. So first we need to know the tissues are healthy. So we are not placing implants in patients with uncontrolled periodontal disease. It's a risk that I would not advise you to take. And you should also be probing once the implant has been restored to have the baseline pocket depth measurement. Angled screw retained crown more favorable than a cement retained crown. As long as there are no excess cement, there is no excess cement, it's the same. So as you can see, in terms of the prostheses, and if you go through the paper in detail, a screw retained crown seems to be within, properly fitted screw retained crown seems to be within the green part of the diagram of the risk. But if you have a cement retained crown, a cemented crown where there are no excess cement, there is no excess cement, then it's the same. And the last question from a, well, from a Galaxy phone, I suppose. How about implant tooth connection, in your opinion, as a risk for late peri-implantitis in comparison to implant bridges? Seems it's not a risk according to the newest assessment. I'm not a prosthodontist, but I don't really see a lot of sense in splinting a tooth that has a periodontal ligament to an implant that has a rigid fixation to the implant. I haven't read the recent guidelines or the recent evidence on this topic, but from what I've read previously, I would not advise. I don't think it plays a role into the development of peri-implant disease if it's cleansable, although we saw that overload can be one of the possible risk indicators associated with a low level of evidence to peri-implantitis. Thank you very much for watching today. Louise, was the sound and the image better today?
Yes, it was.
Brilliant. I moved to the ground floor, closer to the internet source. I hope you've all enjoyed today's webinar. I'll just put my email address once again. Thank you very much for watching. We'll all be together again, working and lecturing face to face. If not, I hope I'll see you soon in a new webinar. Stay safe, stay home. I'll see you soon.